Let's begin with the case. The case begins with a call to me from ENT. And he's calling me because he's concerned about a kid that he's going to send to me. And he is sending the kid to the emergency room. And he's worried about myasthenia, basically. He's a 14-month-old healthy baby boy, and the ENT had just performed an elective laryngoscopy. And soon after the laryngoscopy has ended, the ENT surgeon actually noticed bilateral ptosis, or bilateral droopy eyelids, and new onset stridor that occurred, that wasn't present immediately prior to the scope. The reason that the laryngoscopy was happening was because of a recent history of new onset stridor. And the kid was being sent to the emergency room, and the emergency room is also paging me, stating that they are worried enough that they want to put the kid into the ICU. And again, both groups of physicians are concerned for myasthenia. And this case does represent a dilemma in diagnosis. So I talked to the mom as I am in the emergency room, and there is normal pregnancy and delivery. It was a vaginal delivery at 40 weeks gestation. And for the first 2 months of life, the child was bottle fed because of mother having mastitis. Subsequently, breastfeeding went without a hitch. All the checkups with the pediatrician were completely normal, and the kiddo did pass his first hearing test. His developmental milestones were at the earlier end of normal. First word at 9 months, first step at 9 months, walking at 11 months, and sitting at 6 months, so very typical. As I'm talking to the mom, she says, you know what, at about 1 year of age, he's 14 months now, at about 1 year of age, she says, you know, I did hear him breathe unusually loud and perhaps even gasping compared to other kids that he was playing with. And he had just got into daycare. And daycare also noticed, the people at the daycare also noticed that he is also gasping while he's playing throughout the day. And since daycare started, he has had many more exposures to viruses. And overall, the parents are reporting there's more fatigue, more sleep, gasping now with every step as opposed to with an infection previously, and that he falls on his butt a lot more, but he gets up on his own, but it's unusually frequent. And again, he's gasping, and the gasping is becoming more pronounced with every upper respiratory tract infection. Because of those concerns, that is why they went to their pediatrician first, who then sent the kiddo to ENT, and that is why the laryngoscopy was happening. Now, the 4 days prior to the scope, he did have a URI. He was actually recovering really well. But that weekend, the mother said that she noticed perhaps more episodes of choking, which she cannot recall happening earlier in life. They had abated at the morning of the laryngoscopy, and they proceeded with the procedure. And that is when the stridor returned after having recovered from that recent URI. On examination, he is very playful. He's in a crib. He's actually just going around the crib. He does have a nasal cannula in place. He looks otherwise healthy, normal color. He's playing with his toys. I can hear him babbling. It doesn't sound unusual. He's very interactive with me, and he's trying to grab my really shiny reflex hammer through the bars. On cranial nerves, he has great tracking, great fixation, bilateral ptosis. Remember that the ENT surgeon noticed bilateral ptosis. I actually, later on in the day, noticed unilateral ptosis, which made me think, okay, this is fluctuating quite a bit, even throughout the day. And it's a little hard to guess in some kids, but I thought his cheek sagged a little. It was open, and it was kind of fallen. And his mouth was open at baseline. Having seen multiple supposedly normal babies, there are kids who have their mouth open at baseline and other kids where it's closed, so I'm always hesitant to judge based on just one thing. And the kid is actively drooling. Mind you, he had a milk bottle in the crib. He grabs it with one hand and he just slams it down, and he is able to drink that milk very vigorously and does not seem to choke or cough while he's doing this. I do notice that he has to hold his head back a little bit like this when he's looking at me or when he's observing things around the room. I do notice the stridor is very audible. And when you pick him up on axillary suspension, he has some axial hypotonia. The shoulders go towards the ears. And he did fall multiple times in the crib. He would stand up, fall on his butt, and get up on his own. Did not notice a Gower maneuver, but he would sometimes pull on the bars to get up. On pull to sit, he did have a head lag. And he is able to reach above his head very well without any hesitation on both arms. Reflexes were normal, and I did pull him out, made him walk, and he seemed to have a normal gait, no Trendelenburg, wasn't clumsy or prone to falling. This is a picture of him. I actually think the photo was well after a week. I realized that the timing of the photo is wrong, but this is what he looked like on one of his examinations. He is otherwise does not look dysmorphic. But you can notice the ptosis in the one eye, and mind you, I did notice bilateral ptosis at some point. His mouth is open at baseline. Obviously, he's trached on the picture, but initially, you can hear the audible stridor. Okay, so data, I had a TSH and CK, they were normal. An MRI chest was done by the ENT. He was looking for anything else that can explain the stridor, anything near his larynx that could potentially cause laryngeal weakness. Nothing was found in his chest or in his axial muscles or the neck muscles that could explain stridor. Although I didn't have it at the time, acetylcholine receptor antibodies and MuSK antibodies were negative. A brain MRI was done with and without contrast, and no enhancing nerves were found, and there was nothing unusual about the nerves, the cranial nerves. There were a few foci of susceptibility in the cerebellar hemisphere, and I did not know what to make of it at the beginning. I just tabled that. The results of the laryngoscopy was that there was bilateral vocal cord paralysis, and there was almost no abduction or adduction of the vocal cords. So I do what I normally tell my residents to do, which is to localize. So immediately I'm thinking neuromuscular junction. And their concern was for myasthenia, and it is, quite frankly, on my differential. It's fluctuating ptosis. The kid has stridor. He has difficulty managing upper respiratory tract infections. Yeah, it sounds like potential neuromuscular junction disease, so I put that on my differential. The next thing I actually did not do initially, which is why it's a learning case, there is a second localization for this. This can potentially be multiple cranial nerves. And I will tell you that the reason I didn't put that on was because he was fluctuating so much. I did not think of that as a second localization. I think I should have adhered to my own advice that I give to my residents is if you have 2 localizations, keep them on the board and then come up with a differential for each one so that you can eliminate each one and not miss something. So autoimmune myasthenia was actually highest on my differential. A close second was congenital myasthenic syndrome. And then in retrospect, riboflavin transporter deficiency based on the multiple, if you localized the cranial nerves. What I did at the time, because I did not have antibodies yet, they were just still cooking, I treated the kid with prednisone. I figured if this was autoimmune myasthenia, he will probably improve maybe even within a day, at least somewhat. He's in the ICU. He was just being monitored at the time. He did not need imminent intubation or anything. And I figured I'll treat him with prednisone, see if there's any improvement. And I had basically IVIG ready to go. And we actually started IVIG soon thereafter. Unfortunately, by the next day, the IVIG started, but there was no effect from steroids. And I was getting worried that this was not autoimmune myasthenia, and in fact, it was congenital myasthenic syndrome. Because we had it available at my institution, we decided to proceed with whole genome sequencing because I told the ICU team this could be CMS, and back then it wasn't freely available. So we proceeded with whole genome sequencing, trio, mom and dad included. And that is when it came into stark reality to me that I actually missed the diagnosis. I kept thinking that this was congenital myasthenic syndrome. I didn't think about other things it could be. And the findings on the whole genome trio is an SLC52A3, 2 variants. One is a likely pathogenic mutation and the other one is a VUS. And this is the riboflavin transporter deficiency. One is a C to T change resulting in a leucine to phenylalanine change, and the other one is a C to A change from changing the amino acid from threonine to asparagine. And they are indeed in trans. So one is from mom, one is from dad. So this is, as soon as I saw it, like, yes, this is more than likely the cause, even though there's one VUS. So final diagnosis is riboflavin transporter deficiency 3. It has some nice eponyms that we no longer really use, Brown-Violetto-Van Lery syndrome or Fazio-Landau syndrome. And the take-home message, or rather the actual presentation of this can actually vary quite a bit. It's a progressive neuropathy, cranial nerves and body nerves, basically. And it can range in its onset from anywhere from infancy to early teens, and it is progressive without treatment. Cranial nerves that are typically affected include cranial nerves 2, 8, and 3 are classically earlier on. And yes, indeed, this kid did have stridor, so he had cranial nerve 10 involved as well. The optic nerves, you won't know this until you do a fundoscopic exam or the kid presents with a nystagmus. And sensory neural hearing loss was not a presenting symptom, although it is commonly a presenting symptom for this disease. It wasn't for him. Because he did have normal tracking, but ptosis can separate from the eye movement weakness in this condition, and facial weakness I think I did appreciate, especially with the drooling and the sagging face. Dysphagia was present later on, and if the disease goes on, tongue fasciculations, tongue atrophy, and weakness is very common, in addition to the stridor that comes from laryngeal weakness. In the motor neuropathy portion of this, it's actually motor and sensory, but the motor weakness overshadows the sensory exam so much you can't actually get ataxia, and if a kid is cooperative enough, you might be able to figure out that there's a sensory element to this. But he's so little, I'm not going to be able to get a good sensory exam on him. If in a patient who has untreated riboflavin transporter deficiency, they can actually look like an ALS patient with bilateral flail arms, where it's just hanging by the side. This is in an untreated case, so it does have a tendency to look more like affect the upper extremities more than the lower extremities. Proximal more than distal. This could be severe distal hand wasting, absent reflexes, axial weakness, so much so that they will lose trunk support and trunk strength, and they have a classic head drop. These kids can actually possibly even walk for a short period of time with a head drop. Invariably, in the untreated form, respiratory insufficiency is usually what historically caused significant morbidity and mortality. Cognition is typically spared. Here is a publication demonstrating, you can see significant head drop across the board. You can see that the trunk has to be supported, but they're able to bear their weight. And the arms are just hanging by the side, which is very characteristic of this condition in the untreated case. With treatment, the hope is that you can rescue the function of these nerves. If you can look at these hands at the bottom, you can see it looks very similar to an ALS hand, where you have severe atrophy of intrinsic hand muscles. On visual evoked potentials, bears, they are abnormal. EEG could be slightly abnormal with excessive theta activity, And look, the brain MRI can actually, for the most part, be normal, but some very nondescript T2 hyperintensities can be found in the cerebellum, subcortex, or the brainstem, just like in this child. Now it made sense in retrospect. Very briefly, for your knowledge, the riboflavin transporter is on your enterocytes. You get your riboflavin from a variety of foods, meats, eggs, fish, vegetables. You get riboflavin from multiple sources. It's vitamin B2. It needs to be taken up by active transport. Forgive the diagram. It shows an arrow outward. It's an active transporter into the cell. And there are other transporters that help with transport across other membranes. And it's a necessary factor in the generation of flavin mononucleotides and hence flavin adenine dinucleotides. And the mononucleotides is needed for mitochondrial respiratory chain function, and the adenine dinucleotides are needed for beta fatty acid oxidation, which then feeds into the Krebs cycle. And the treatment is to, as soon as you recognize this, to start riboflavin supplementation, starting at, and you can toggle anywhere between 10 to 50 milligrams per kilogram per day. You start out low and you ramp up to the highest tolerated dose. And it could potentially be life prolonging. So the take-home points that I learned from this case is, remember that riboflavin transporter deficiency is a neuropathy, and it can mimic neuromuscular junction disease. And that immediate treatment with high-dose riboflavin can actually help save those neurons and improve strength and possibly even change outcome. I will admit that for the 7 days that we were doing the whole genome sequencing, I did not tell the ICU to put the kid on riboflavin supplementation because I did not think of it. So for 7 days, he did not get it. But fortunately, as soon as that result came back, and our institution is known well for having a very rapid turnaround time on the whole genome, that saved me. We did start him on riboflavin supplementation. You need genetic confirmation to actually diagnose this. And I'll be happy to take any questions. Thank you.
Or do you think